Good evening and welcome to this evening's Immunisation Coalition webinar. Our topic this evening is meningococcal disease and update. I'm Andrew Baird. I will be your moderator this evening. I'm a GP in Melbourne and a member of the Immunisation Coalition. I acknowledge the traditional custodians of the various lands on which we work today and the Aboriginal and Torres Strait Islander people participating in this webinar. I pay my respects to elders past, present and emerging, and I celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of Australia. Presenting tonight's session is Professor Jim Buttery, who will be speaking for about 40 minutes. This should leave us with plenty of time to answer questions and comments which you may have. Please type in your questions through the Q&A button, not through the chat box, and you can do this at any time during the session. You will find the Q&A button at the bottom of your screen. We will try to answer as many questions as possible during the session, but if we don't get through them all, we will send responses to you in a few days' time. Tonight's presentation is being recorded. All participants will be on mute. At the end of tonight's webinar, you will receive a 2-minute evaluation form. Please fill this out so that we can continuously improve our education activities. I'd like to introduce Professor Buttery. Jim Buttery is the inaugural Professor of Child Health Informatics at the University of Melbourne. He serves as the Chief Research Information Officer and an infectious diseases physician at the Royal Children's Hospital in Melbourne. Additionally, Jim leads epidemiology and signal detection at the surveillance of adverse events following vaccination in the community. He heads the Health Informatics Group at the Murdoch Children's Research Institute, and he co-directs the Global Vaccine Data Network. Jim's research focuses on leveraging real-world data to advance infectious disease in epidemiology, vaccine safety, and vaccine effectiveness. He has pioneered Australia's first state-based public vaccine safety report, developed syndromic vaccine safety surveillance methodologies, and established the Vaccine Safety Health Link, which is a unique statewide vaccine safety data linkage system. Thank you very much for joining us, Jim, and welcome.
Thanks very much, Andrew. I'd also, first of all, like to thank the organisers for the opportunity to speak, and like Andrew, acknowledge the traditional owners of the lands on which we're attending from today, which for me is the Wurundjeri people of the Kulin Nation, and pay my respects to elders past and present. I'll just share my slides. So hopefully you can see those now. So this is a fairly quick run over meningococcal disease, which is a relatively rare but often devastatingly severe infection that occurs only in humans. So our objectives are to review the epidemiology of invasive meningococcal disease, or IMD, identify the serogroups causing IMD, describe who's eligible for both the meningococcal glycoconjugate ACWY vaccines and the protein-based meningococcal B vaccine on the NIP schedule, look at some of the recent changes at a statewide level in South Australia, Queensland and Northern Territory, and then have a think about what the potential impact on rates may be in other states if they implemented a MenB program. So, as I mentioned, meningococcal disease is relatively rare, but it has a high mortality rate, typically between 5 and 10%, with the 10% really being around the septicemia compared with meningitis, which has a lower mortality rate, but has other sequelae as well. It's caused by the obligate human bacterium, Neisseria meningitidis. In other words, it can only be transmitted human to human. There's no animal vector or environmental source. And globally, 5 serogroups cause the vast majority of IMD, with another group, serogroup X, emerging most recently. In Australia, there are really only 3 main groups following the success of the Group C meningococcal conjugate vaccine was introduced in 2003, and with the majority of disease caused by serogroup B, and then serogroup Y and W causing the rest of disease predominantly. So as I mentioned, the only place meningococcus lives is in humans, and its niche is in the back of the throat, in the nasopharynx. And colonization is common. It's typically transient. You can have it multiple times. The most common time to be colonized is in adolescence, and the vast majority of times we are infected with meningococcus. We're totally asymptomatic, remain well, and the bug goes away again. The duration of that carriage varies, but it can vary anywhere from just a few days to several months. As I mentioned, it's more common in adolescents, so typically about 10% of the population are asymptomatic carriers, but that can jump up to more than 20% in older adolescents and young adults, where the mixing of nasopharynxes can be more common at that age. And we think that asymptomatic carriers are probably the major source of transmission of invasive meningococcus. And there's an immortal study done by Jo Tully, who's a Victorian paediatrician, but when she was doing her MD in the UK, showing that open mouth kissing is an independent risk factor for invasive meningococcal disease. She managed to get the title of snogging study past the BMJ. So as I mentioned, meningococcal disease can be deadly and completely devastating, with the 5 to 10% mortality rate, even with appropriate antibiotic treatment, and approximately up to 30% of survivors can have long-term sequelae. They typically include skin scarring, limb deformities, sensory neural hearing loss, and neurological deficits. And as we're learning more subtle deficits are also emerging that may be slightly more common. In terms of the symptomatology, it can vary from presenting incredibly rapidly, just over a few hours, all the way through to a more indolent presentation and the classic trap of people presenting with a flu-like illness that goes on to become more severe. So about 50% present early with fever, drowsiness, and more general symptoms. And then in another 20 to 50%, as I mentioned, you get more of the flu-like symptoms, general aches and pains, in particular sore legs, headache, and even other symptoms that make people think it's a viral infection, such as sore throat or a runny nose. Less than a fifth show signs of hypovolemia with cold hands and feet, pale skin, and respiratory difficulty. And then if it progresses, you can then see the classic hemorrhagic rash or petechial rash early, which can then develop into a more profound hemorrhagic rash. So if you like, non-palpable purpura. So in other words, a classic test with the glass. If you put a glass on it, the rash does not go away, whereas most other rashes do. And then it can progress to including neurological symptoms, meningitic symptoms, and then subsequently loss of consciousness. So as I mentioned, the typical presentation of invasive meningococcal disease is septicemia and meningitis, but you can also get atypical sites, including pneumonia, septic arthritis, heart infection, in particular pericarditis, and ocular infection is a well-known uncommon variant of meningococcal disease. And as you can see, there's various forms of the meningococcal rash up the top, if you like, the classic advanced lesion, more subtle lesions in the middle, including some petechiae, and then a baby covered in a necrotic rash on the bottom. An example of severe invasive meningococcal disease is Arthur, who presented in 2017 with a severe serogroup Y invasive meningococcal disease. That was prior to the availability of the vaccine then. And he was in hospital on ECMO for a prolonged period of time and fortunately made a good recovery, but required 24 operations, predominantly plastic surgery, as part of his recovery. The case fatality rate varies. Meningococcal W typically has a slightly higher mortality rate than meningococcal B, which can more commonly present, especially in early childhood, with meningitis, which has a lower mortality rate, but still 1 in every 20 people dying. As I mentioned, the sequelae following meningococcal disease are beginning to be understood better now. And that's really being led by Helen Marshall in South Australia, who's been conducting a long-term follow-up case control study to explore some of the more subtle defects, including neurological and mental health aspects of this long-term sequelae of invasive meningococcal disease in teenagers and young adults. Those results should be out next year. So meningococcal bugs, like all encapsulate bacteria that cause meningitis, in other words, Haemophilus influenzae type B, for which we've had a vaccine for many years and a very successful one, pneumococcus, which we've had a number of vaccines, predominantly using the Prevnar vaccine, initially starting with a 7-valent vaccine, currently a 13-valent vaccine, and increasingly more serotypes being covered of the 90 pneumococcal serotypes available. As I mentioned, the serogroups for meningococcus that cause disease are predominantly 5, A, C, W, and Y. All of those, the vaccine is able to target the sugar on the outside of the bug, or the capsular polysaccharide. And that's been able to become a very successful conjugate vaccine. We use the polysaccharide sugar, we glue it to a protein, and that tricks the infant's immune system into responding very strongly at that. Unfortunately, the sugar on the outside of group B meningococcus is a self-antigen and resembles an antigen found in human tissues, including the human brain. And so our immune system does not allow us to use a vaccine targeted against that antigen. And so developing a group B vaccine has been a bit of a holy grail for a long time, and was really an amazing piece of science where they, for the first time, used reverse vaccinology by starting with the DNA of the bug and worked backwards to identify what the best candidates for a vaccine would be, which is when they've come up with the Bexsero vaccine, which contains subcapsular proteins, which are common to many of the group B meningococcus, as well as outer membrane vesicles. And that's what's been the Bexsero vaccine. So all meningitis bugs, or encapsulate bugs, in other words, bugs that cause invasive disease that are covered by these capsular polysaccharides or sugars, have a typical appearance of when they're most common. So for the first 3 to 6 months of life, all babies are covered through the placenta by the protection they get from their mother. And so we typically don't see the rates rise for meningococcal disease until anywhere between 3 and 6 months of age, which is when the peak, because they've lost the protection from mum and they haven't developed their own protection. And so the peak disease is typically under 2 years of age, as you can see in the inset graph there, before any vaccination. These are the rates in Australia. And then another spike, as I mentioned, in the adolescent years, which we assume is due to a combination of increased crowding in many situations, for example, colleges, as well as increased sharing of nasopharyngeal secretions. And as you can see, that was typical also for Haemophilus as well as pneumococcus in terms of that infancy peak as well, although we don't see the same peak in adolescence for those two. Other risk factors for meningococcal disease are the immature immune system, because babies under 2 don't respond as well to polysaccharides, or the sugars on the outside of the bugs, which is why the conjugate vaccine tricks the immune system into responding. Prematurity is also an independent risk factor. The impaired immune system is predominantly complement deficiencies and asplenia, but there's also an increased risk in patients with HIV. And then things that irritate where the bug can live, including smoking and respiratory tract infections. And then finally, as I mentioned, social factors that increase the chance of coming in contact with asymptomatic carriers. But the vast majority of cases occur in previously healthy people that do not really have identifiable host risk factors. So what's meningococcus got to do with the Vietnam War? The Vietnam War was where we developed our understanding of how to protect against meningococcus. And what Goldschneider, Gottschalk, and Artenstein did was they took a group of recruits going through boot camp at Fort Dix in New Jersey during the Vietnam War. They took their blood before they entered boot camp, took their blood at the end of boot camp, and worked out what the difference was between those who developed meningococcal C invasive meningococcal disease and those who remained healthy. And the attack rates were so high in boot camps that they were able to get a decent number of invasive cases. And the difference between the ones who were protected, if you like, and the ones who got disease was the protected ones were much more likely to have antibody directed against that capsular polysaccharide. And that immunology study from the Vietnam War is what has powered all of the meningococcal vaccine development we've had since then. As I mentioned, the other places where we get massive outbreaks of meningococcal disease is where there is major clustering of human beings, and that can include mass episodes like the Hajj and the Umrah pilgrimage, as well as other settings where there's clustering, whether that's in childcare settings, refugee camps, or university colleges as well. So what's the epidemiology of meningococcus in Australia? So as I mentioned, prior to the implementation of the Group C meningococcal vaccine in 2003, meningococcal C was the dominant serogroup causing infection, followed by Group B. Well, actually, that was in the UK. In Australia, Group B had probably always been the most common. And so what you can see here in the lower line is following the introduction of Men C, there was a rapid decrease in Group C disease, and it's remained low ever since, whereas Men B was largely unchanged for much of that time. Subsequently, we saw a rise in Group W and then Group Y disease in the late teens of the 2016 onwards, and we introduced the quadrivalent Men-A-C-W-Y vaccine into the NIP in 2018, added that to the adolescent schedule in 2019, and as you can see, there's been dramatic reductions since then. You can also see a reduction in Group B disease during that time, and it's no surprise that that was due to the opposite of clustering events, which was the pandemic, where there was a reduction in human mixing and associated reduction in many infections that require human contact to spread, of which meningococcal disease is one. So this is a breakdown by age and the serogroup, and as you can see that at every age in Australia for invasive disease, Group B disease dominates. And interestingly, although historically 6 months has been the peak age, it's slightly earlier in Australia in the 3 to 6 month period where we see the highest rates. And then again, as everywhere else in the world, Australia is no exception. The 15 to 19-year age or the teenage years are where the second peak is. So as a longer historical example, the epidemiology from Victoria, and that really owes an immense amount to Kath Taylor, who is a public health physician who previously worked in Department of Health Victoria. And she painstakingly compiled meningococcal infection notifications all the way back to 1936. And what you can see in this hand-drawn graph, which was all the computers available for most of that time, and slightly larger, is that there are major peaks during that time. And that's better represented, as you can see here, when it's been converted to a graphical display that was also done by Lucinda Franklin. And the major spikes occurred with massive troop mobilization, first of all, in the Second World War, and then smaller ones with other mobilizations occurring, not only troops going overseas, but also troops being clustered in training centers. And then a rise in meningococcal notifications in the 90s, leading to the implementation of the Group C vaccine, and but then still higher rates, most of which is meningococcal B. And that's really illustrated here. The blue is Group B disease, and this is rates up to 2013. But what you can see is Group C was fairly dominant in Victoria. And then in 2003, when the vaccine is introduced, it's almost wiped out Group C disease, which has been a major success. And again, what you can see for total disease, this is all the way up to almost the end of December last year. We've had significant reductions with the MenACWY program in 2017, 2018, really significantly reducing those. And so now B is overwhelmingly the dominant serogroup causing disease. So in summary, the majority of cases in Australia are caused by B overwhelmingly, as well as W and Y. B remains the dominant strain with peak infection rates in infants under the age of 12 months, and then a smaller spike in teenage years. Globally, what do we see? So in sub-Saharan Africa, also known as the meningitis belt, we've seen massive outbreaks every 5 to 12 years historically. And then there was a major implementation of predominantly this disease as being Group A disease. And the Menafrovac project, which was implemented around about 2010, has finally, fingers crossed, wiped out the toll that this massive outbreaks, as you can see, the number of cases in each of these outbreaks in the hundreds of thousands has been eradicated by a highly successful conjugate vaccine program. But globally, meningococcus is still the most common cause of meningitis, second only to viruses, and causes far more morbidity than viruses do. And in terms of deaths, this is comparing 1990 with 2019. The success of the Menafrovac program has significantly reduced deaths, but it still ranks number 2 in global deaths due to invasive disease. Globally, the serogroup distribution varies a reasonable amount around the world, with B predominating in most high-income countries, but a fair bit of variation. And as I mentioned, the serogroup X has been emerging, in particular in Africa, in recent years. And that's that light blue that you can see in Africa with a red X over it. In Europe, again, pretty consistent overall, with B dominating in most places, but a significant north-south variation, with B being the dominant strain in Southern Europe, and more variation in Northern Europe, where many countries do not have a Group C, a Group Y program, ACWY program. So, as I mentioned, we saw a major effect during the COVID pandemic on the rates of many infectious diseases, and that was no exception. This is UK data, and as you can see, during the pandemic, people stopped mixing, and meningococcal disease didn't go away completely, but was massively reduced. And importantly, following the relaxation of isolation guidelines, meningococcal disease has come back. So the vaccines available for meningococcal disease for healthy infants, for non-Indigenous babies, they receive a single dose of, under the NIP, they receive a single dose of the quadrivalent ACWY vaccine at 12 months. The MenB vaccine is available but not funded under the NIP except for Aboriginal and Torres Strait Islander people and other special medical risk groups. And then you can receive all these vaccines throughout the subsequent period. And then there's another funded ACWY vaccine in the teenage years and in some states also for the MenB program. For groups that are at increased risk, including Aboriginal and Torres Strait Islanders and those in the special medical risk groups, they have funded vaccine for both MenB and ACWY. And we still use the quadrivalent conjugate vaccine for travellers, especially those attending mass pilgrimage events such as the Hajj or travelling to the meningitis belt. So both MenB and ACWY are recommended in the immunisation handbook for the epidemiological high-risk groups, which are infants and children under 2 years of age, healthy adolescents 15 to 19 years, those in a slightly broader age range who are living in close quarters, such as university colleges or those that are current smokers, and then Aboriginal and Torres Strait Islander people from 2 months to 19 years, those who have medical conditions that increase their risk of invasive meningococcal disease, and laboratory personnel who are at a much higher rate of meningococcal disease if they handle meningococcal samples. We also recommend the quadrivalent vaccine, as I mentioned, to those travelling where invasive disease is more common or mass gatherings. So what the NIP funds is ACWY at 12 months of age, and then again in adolescents, and then people of all ages who have specific risk conditions that increase their risk. Predominantly complement deficiencies, asplenia, HIV, and hematopoietic stem cell transplants. And then under the NIP, MenB is funded at a national level for Aboriginal and Torres Strait Islander infants over 2 months of age, which are catch up for all under 2 years, and then those with specific risks that increase their risk of IMD. And then, as I mentioned at the start, there are specific state programs. South Australia was the first to implement a state program, and that was for infants at 12 months and adolescents in year 10. Queensland has subsequently implemented a similar program with also a catch-up program for children aged over 12 months to 2 years. And then more recently, Northern Territory, also for infants up to 12 months and year 9 students, with a catch-up for children between 12 months and 2 years, and for adolescents 15 to 19 years of age. And the MenB vaccine is available, and as is ACWY, from 2 months of age on private prescription for anyone who wants to increase protection. So in summary, the handbook recommends MenB vaccination for at-risk groups, including all children less than 2 years of age and adolescents 15 to 19 years of age. MenB vaccine is on the NIP for some, but not all at-risk groups. And some states provide state-funded Bexsero for babies and adolescents. So I'll talk a little bit about Bexsero specifically. So this is the dosage schedules for Bexsero. At all ages, there's a 2-dose primary immunisation schedule with the interval between the primary doses being 2 months or more. It doesn't matter if it's more in terms of the ability to represent a second dose. And then a booster vaccine, for those that receive it during infancy, they need a booster dose in the 2nd year of life. And then for those that receive it in the toddler years, the booster dose should be 12 to 23 months after the 2nd dose. And then for adolescents and adults, the need for a booster dose has not yet been established. So in terms of Bexsero safety, what we do know is that Bexsero is a highly reactogenic vaccine. When administered alone, it's got a fairly similar reactogenicity profile to pertussis-containing vaccine combinations, but when administered with the routine infant vaccines, the rate of systemic reactogenicity in particular is higher. So common adverse events are, as I mentioned, the systemic reactogenicity as well as local reactogenicity such as pain, swelling, and induration. In adolescents and adults, it's systemically better tolerated in terms of fever, although still common adverse events in terms of malaise, headache, nausea. And my two children, now adults, who had this when they were teenagers, certainly commented to me about that, although happily had their second dose. Importantly, there's no increase in the incidence or severity of these adverse events as you progress in the vaccination series. So the product information supports co-administration with most routine vaccines, and there's no evidence of decreased immune response following co-administration. What is known is that, and the safety of those co-administered vaccines are not affected by concomitant Bexsero. However, the rates of fever, tenderness, and irritability are increased, especially in infants with co-administered. You need to use separate injection sites if more than one vaccine is administered at the same time, either alternate limbs or if you're administering more than a few vaccines separated by more than 2 centimeters. So these are essentially the evidence showing that co-administration shows essentially equivalent immune responses for co-administered vaccines as well as for Bexsero. But with co-administration, you do get a significantly higher rate of fever, especially in infants. We did a small study after the implementation of the MenB vaccine in the UK in the early noughties. And what we found was that there were more presentations with fever to the emergency department in that, but when the vaccine was introduced in the booster study and in toddlers, there was no increase in febrile convulsions, and that's been consistent everywhere. So fever rates are higher, but there is not an increase in febrile convulsions with Bexsero. So these are, as you can see, the systemic adverse events, which it's a relatively high rate when they're co-administered, a lower rate if you're giving it separately. And many people choose, if they're concerned around fever, to have them asynchronously with the routine vaccines. What we do know is that co-administering with paracetamol significantly reduces the rates of fever and irritability. So in real-world usage, the safety profile has been studied extensively in millions in the UK, in Canada, and also in South Australia. And the adverse events are the ones that we knew about from the clinical trials. We've not discovered new rare adverse events, and so far the safety profile seems to be good, with the caveat that immunogenicity is obviously greater, especially with co-administration. And this is really just underlying that if you look at the fever rates, even if you give Bexsero alone compared with co-administration, it's significantly higher with co-administration. And we know that we can reduce these rates with prophylactic paracetamol, and that's essentially given as one dose at or ideally 30 minutes before vaccination, and then 2 additional doses of paracetamol in the next 24 hours, separating each dose by 6 hours. And paracetamol does not change the immune response to the vaccine, at least on the limited studies, although that's not been completely finalized. As I mentioned, if you need to give 2 vaccines in one thigh, make sure they're separated by at least 2.5 centimeters. So the standard contraindications for Bexsero exist if they've got a hypersensitivity, but it's a relatively limited range just to the active substances or any of the components of the vaccine. It is important to note that Bexsero, while being actually a revolution in vaccinology and being the hardest of all the meningococcal serogroups to develop a vaccine for, because they're not able to use a capsular polysaccharide and they have to use the subcapsular proteins. The subcapsular proteins are more variable across different Men-B strains than the capsular polysaccharide, which is standard. And what that means is that it covers most, but not all, of Group B strains circulating in Australia. And we know that the vaccine covers about 76% of circulating Group B strains in Australia. If they've got a severe febrile illness, you would certainly postpone vaccination, and individuals with an impaired immune response may also have a reduced antibody response to this. So does it work? As I mentioned, what's in the vaccine covers about 75% of the Men-B vaccines in Australia. For children less than 5 years of age, there's international studies from the UK. This is a representative study that's more recent from Spain, which showed that in children under 5 years of age, an infant program was 71% effective against invasive disease due to Men-B. The initial results from South Australia after the first 3 years that were published in 2023 showed introducing the funded program reduced Men-B disease across the state in infants by 63% and 79% in teenagers. If you just looked at those that had a full immunisation course, the effectiveness was much higher. It was 91% in infants and 83% in adolescents. And the good news was that there also in adolescents appeared to be some protection against gonorrhea. And that has been confirmed initially in a New Zealand study with the prototype of these vaccines, but also elsewhere in the US, where because there's some shared outer membrane vesicle components across meningococcus with gonococcus, what we've observed in multiple settings now is that there is partial protection against gonorrhea in Men-B vaccine recipients who have the 4-component Men-B vaccine, or Bexsero. That immunity does appear to wane after about 3 years partially, but nevertheless, it's very encouraging. So in summary, Bexsero is the only Men-B vaccine indicated from 2 months and above. There are no significant safety concerns with Bexsero when it's co-administered with other routine pediatric vaccines. It does have increased reactogenicity, but prophylactic paracetamol significantly reduces that. It's important that what has been a consistent finding is that awareness of the Men-B vaccine is relatively limited, and many parents are not fully aware that there's different meningococcal vaccines protecting against different serogroups. As with pretty much most of the discussions we have with patients, the details of what we discuss is not well recalled, but many patients don't recall having a discussion about Men-B vaccine on their encounter with a healthcare professional. What we do know is that recommendation from a medical practitioner has been shown to be a significant predictor of willingness to have their child vaccinated with Men-B vaccine. Although it's a relatively expensive vaccine, it's important that families are aware it's available so that they can make their own decision. So the keys to successful vaccination is education, communication, and ideally vaccination. It's important to know that Men-B vaccine The reason it's not currently on the national immunisation program is that although it's a effective vaccine, it's got a proven good safety record. Because meningococcal B is a rare disease, the cost effectiveness in the process that Australia uses to fund medicines and vaccines has been very hard to demonstrate with such a rare disease. So, in conclusion, we've seen a global reduction, thankfully, in the incidence and mortality, especially in Africa, of meningococcal disease. And that's due to the glycoconjugate, in other words, gluing a protein to the capsular polysaccharide to trick the baby's immune system. And the more recent Menafrivac includes 5 strains, including the new X strain as well. Group B dominates globally and especially in Australia, and that includes a post-COVID-19 re-emergence. We've seen an emergence of serogroup X in Africa. We know that ACWY vaccines in Australia are effective, and we know that MenB vaccine is also effective. Thanks very much.
Jim, thank you very much for a comprehensive and fascinating overview of epidemiology, clinical features, and the vaccinations themselves in regard to invasive meningococcal disease. We've got many questions. I'm not sure if we're going to be able to tackle them all in the time, but if you're okay, Jim, I will try and let's see how we go. And many of them follow on directly from what you've been discussing. So I thought I'd try the first one, something completely different, and that was a question which was, can the use of Bactroban nasal ointment reduce the risk of infection?
It's a fascinating question. I'm not aware of any evidence. My best guess would be no, because although Bactroban is effective for nasal shedding, we think that the nasopharyngeal secretions are transmitted in multiple ways as opposed to just nasal shedding. And so my best guess would be no. The other thing is that Bactroban predominantly works against gram-positive organisms, and meningococcus is a gram-negative.
Thanks, Jim. I think that helps to explain the situation with Bactroban. There are several questions around protection for people who have risk factors such as splenectomy or other asplenia causes. And it's really to what extent do the vaccines protect these people who are immunocompromised or immunodeficient?
Yeah, it's a good question. So we know that if we've got good data from patients with splenectomies that they mount an effective immune response, and that those immune responses are correlated with protection in studies. The problem we have is that even in more highly susceptible patients, such as those without spleens, because meningococcal disease is relatively rare, it's almost impossible to generate effectiveness data. All meningococcal vaccines have been licensed on the basis of their ability to induce protective immunity. And we see that same protective immunity in asplenic patients.
Yeah. So I'll follow on again from immunodeficiency or immunocompromise, and I've chosen this question because it refers to the meningococcal Coca-Cola vaccination. So I don't know if that is a spell check issue or somebody who's chosen that, which I think works very well. And the question is, with degree to say complement insufficiency, what is the level of complement insufficiency in which you regard that as being significant in regard to meningococcal vaccination?
I think there are the question rightly refers to there are some more profound complement deficiencies. I typically would seek advice, but the general recommendation and the funding really revolves around all complement deficiencies. And I don't think I'd be, again, I don't have the ability to differentiate risk apart from other aspects of immunity. And my advice would be that all complement deficiencies would be recommended.
So it's yes or no. You've either got the complement deficiency or not the
Yes.
level. Yeah. So there are some questions around travel overseas, noting the recommendation for ACWY. Should meningococcal B vaccine be recommended as well?
Typically not. For travel, the vast majority of countries people travel to, the risk of meningococcal B is not higher than in Australia. So while if they're in the age group, we recommend Men B vaccine, absolutely, but that's a baseline risk that would be without them traveling anyway. Specifically for travel, Men B has not emerged in any of the mass events to date, and so there's no recommendation for Men B vaccine for that group.
Thank you, Jim. A question now, really somebody who's looking into the future and saying, what about a pentavalent vaccine? We know they've got that in Africa with X. What about a B, ACWY?
They're working on it. I don't think it's that far. I don't have... making combination vaccines is you would think it would be simple. It's an incredibly complex soup that you put one bit in and it changes all the other bits. Having said that, my understanding is that the development is quite advanced, and so I think we will be seeing it sometime in the next few years.
I suppose my follow-on question is, will that be funded?
I spent 9 years on PBAC. I can't predict it essentially comes down to meningococcal disease being a relatively rare disease, but a devastating disease. So we can increase the chance of funding by understanding the full impact of meningococcal disease and by also understanding the full effectiveness. The fact that there may be some protection against gonorrhea can also help in terms of the cost effectiveness, which is how they make the decisions. So the more information we have, the better chance there is to get funded. But it's a rare diseases are very hard to get vaccines funded for them.
Yes, understand. Yeah, I see. And I suppose it follows on a little bit from this. Is Bexsero the only available meningococcal B vaccine?
I think it's the only one in Australia available at the moment. There is Trumemba, which is a 3-component vaccine as well. But my understanding is at the moment there's only Bexsero available in Australia.
A question now regarding a patient who declined to have a second dose of the primary course, an adolescent. And the question is, how much protection will a person get with just one dose? So not completing the primary course.
Yeah, so two-part answer. First of all, some protection. We know from Helen Marshall Bin Wang's study from South Australia that partial immunisation still did convey some protection. We also assume that protection is not likely to last as long either. So one, it'll be reduced, and two, will probably be shorter, but it's not zero.
And another question around this time with boosters. There's been a comment that when did it become routine that infants over the age of 12 months would need 3 doses, so the primary course and a booster, because previously it was only 2 doses, just the primary course from the age of 12 months, just the primary course. I've forgotten that, but can you explain that, Jim?
I can't answer when it became routine.
Sure.
I genuinely don't know. I think it'll be based on predominantly on the rate of decline of protective antibody in that age group, but I don't know when the change occurred. I'm sorry.
Yeah. I think sorry, I apologise. I was just about to reread a second question, which is exactly the same, written in a different way.
I'm glad you didn't, because it was a hard question.
Thank you. Well, we can try again. The question now about Nurofen versus Panadol. So some parents have asked if they could use Nurofen in lieu of paracetamol for prophylaxis for fever. What are your thoughts on that, Jim?
I think what I'd have to say is, while it's clearly an effective antipyretic, we don't have data. We've got a massive amount of data on the use of paracetamol, both at a clinical trial level and also at a population level, and we know it's effective. And so I would stick with what we have the data for.
What we know, which is paracetamol. Yeah. Just going back to again meningococcal B vaccination, we know that it's highly immunogenic and causes the high fevers. So we're talking about that now. The question is about the rarer effects. I think you alluded to some of those when we went through the slides, but the question is, does it cause like Guillain-Barré, for example?
Yeah. So as best we know, no, it doesn't. So during the clinical trials, there was a flag in particular in children around Kawasaki disease. And so that was a adverse event of special interest when it was introduced in the UK. And so we've now got over a decade worth of data, and there does not appear to be an association with Kawasaki disease. I'm not aware of an association with Guillain-Barré syndrome. Um, uh, there are some newer vaccines that do have an association with Guillain-Barré. Bexsero is not one of them.
Sure. Yeah. So again, a bit more Bexsero. If a baby's had, the primary course and the booster, what about having it again as an adolescent?
Yeah, we haven't reached there yet. My best guess is the answer is going to be yes. And because at least at a serological level and what we think is the correlate of protection, by the time they reach adolescence, there's not a lot left.
Yeah.
Whether there's elements of immune memory that may help you is less clear. What we do know is when the UK originally introduced meningococcal vaccines, there was a belief that maybe it wasn't all about the antibody, maybe immune memory would also protect them. And they're following a rise in Group C meningococcal disease, this is back in the Group C days. They shifted their belief that actually it appeared to be that antibody levels were the driving protective factor. So I assume that's going to be the case for Men B, but I don't think anyone knows.
So watch this space and watch the data. So, and I'll have a break from questions because I've got a comment from Kate, who says, "Thank you, very concise and useful overview." So there we go. Break from the questions.
Thank you.
There we go. Question now: why is Bexsero not in the schedule in WA?
I can't speak to the WA Health Department, who clearly have a record of implementing vaccines they believe are important, such as being the first jurisdiction to implement nirsevimab. I, I, I think what goes to most states are reluctant to start an immunization program because it's historically been a national responsibility, and obviously WA is one of the ones that may conceivably be in a budgetary position to look more positively on that. But I imagine it comes down to local priorities, and it was obviously clear that RSV was a major local priority for them.
Yeah, so health economics and so on. It's a while since I've checked. Do you know the cost of meningococcal B vaccine, Jim? What's the latest, availability and cost?
The ballpark figure I've used is somewhere between about $135 and $150 a dose. That may be slightly out of date. Apologies if I am.
Sure. Yeah, that was the sort of figure I was thinking of, but I probably haven't checked for a year. And an interesting question. We talked about Guillain-Barré and other possible risks. The question here is about POTS. So this was an adolescent who, following the Men B vaccine, developed POTS. Is that a recognized association?
No, it's not. So POTS is a really complex condition, and it's an important condition, but one that we know it can occur outside of any vaccination. And then the difficulty we have is when it does occur after vaccination, which it does sometimes, is how do we work out causality?
Sure.
So I'm not aware of any investigations around Men B vaccine and POTS because presumably there haven't been enough cases reported. A similar investigation after HPV vaccine several years ago was performed by the European Medicines Agency, and were not able to find an association. POTS is really difficult because it's very hard to get a big enough collection of patients for us to begin to understand it, but it remains on our conditions of interest for many vaccines because it's regularly pops up as a concern, and I think it's important we take it seriously.
Great. Well, thank you, Jim. In fact, there's a comment from an anonymous attendee, unreferenced, that meningococcal B is listed as one of the causes of the dysautonomia that occurs in POTS. 7% of cases following POTS follow a vaccine, and 40% are stated to follow a viral infection. So there's some data, although I don't know its authenticity, Jim.
I think what we do know is that temporal association is not causation, and we've learned that many times, and also the window period. We don't even know with POTS what a biologically plausible window period is. Nevertheless, we are trying to figure out the best way to study that for all of the vaccines we give in adolescents.
And another practical question for immunisers, Bexsero from the age of 6 weeks. That is stated in the Australian Immunisation Handbook, and then we've talked about from 2 months of age. Is from 6 weeks appropriate?
Yeah, it is.
Yeah.
So we've talked about what's in the product information, which is from 2 months of age. We know that it's been used extensively in the UK with the first dose at 6 weeks, and we know that both it works and its safety profile is no different to that at 8 weeks. So I'm very comfortable giving it at 6 weeks.
Sure. Yeah, exactly. I think we're almost sort of working through them. Again, I've got a comment. Will men be vaccinated as a baby protect an adolescent? I think we've sort of half answered that question already.
My best guess is probably not.
No. So, and in that case, following on, then we recommend a booster at that stage. Yeah.
I think it is highly likely that will be the recommendation.
So, yeah. And another break from questions. So a comment, an anonymous comment. Thank you for a comprehensive and interesting presentation. Question now about microbiology lab staff. How many ACWY vaccines should they have? I mean, every 5 years for how long?
Good question. For how long we don't know the answer. I think every 5 years is a reasonable interval. There are some data from infancy saying if you have many doses, this is back in the clinical trial data, you may start seeing a reduced immune response after vaccination, but we're talking many doses and none of the number of doses we've talked about so far. So it's conceivable if you're getting up to 40 years in a laboratory, those recommendations may change, and hopefully we'll have better information by that stage.
Thank you. And we're approaching 7 o'clock, and there's probably one question which I think is very important for clinicians, and that is identifying invasive meningococcal disease at an early stage, where we have non-specific, symptoms which overlap with many of the other sort of febrile illnesses that we would see in primary care. So the question is, are there any tricks that we can use? Is there anything that we can present, anything we can look for before there's a fulminant presentation, Jim?
I think, it's difficult. It's easy for someone like me. I work in an infectious disease unit in the hospital where patients are really sick by the time they get to see me. So my job's a lot easier than in primary care, where the pretest probability that something is a serious infection is much lower. And so I think probably what I would say is beware the significant leg pain of just calling it flu. So clearly, if someone's got a particular rash, then we need to be concerned. Even though viruses may be the cause, we have to assume it could be meningococcal disease. Where flu-like symptoms but significant pain worries me, and that changes the pretest probability.
Yeah, and we see maculopapular rashes with many viral illness. Is that rash sort of reassuring in that it's not Usually
it's reassuring, but you have to tell the patient if it evolves, because I've seen meningococcal rash start out as maculopapular and then evolve. And so if it evolves into a different rash, then they need to come back.
Yeah. And then another question on the same point was, does CRP help us if we were to see the child in the early stages?
The CRP informs the probability.
Yeah.
So it may help depending on how quickly you get it back, etc.
True. Yeah. So it's not diagnostic, but it may at least probability. But we have reached 7 o'clock, so we're going to close the webinar now. I wish to thank Professor Jim Buttery very much indeed for a very thorough, comprehensive, fascinating presentation covering so much around invasive meningococcal disease. We've all had a chance to learn a lot. And I'd like to thank everyone who has attended for their participation and for contributing to the questions. We had a sort of a late surge of questions, so I'm sorry we've not been able to get to every question, but we'll take them on notice and we'll get back to you. We'll send those out, send the answers out hopefully later this week for you. Our next Immunisation Coalition webinar is an HPV update, and that's on the 12th of March at 6 o'clock Australian Eastern Daylight Time, and that will be presented by Angela Newbound. So registration details for that webinar are available on our website and also in the weekly newsletter. Thank you, everyone. Good evening and stay safe. Thank you.